that has, this has been an idea that's been part of the conversation, you might say, for really 20 years, the idea that every child should have their genome sequenced in some way, and that this should be the blueprint of life. So my funding and my disclosures are here. This work is all supported by the National Institutes of Health. Thank you for your tax dollars and the other funders you see there. And I have served in compensated advisory roles for these companies that you can see there. The program that I direct is called Genomes to People. And we've recently expanded this with a partnership with Ariadne Labs that was started by Atul Gawande here at Harvard Medical School to try to strengthen the impact of our implementation. And at its essence, this is really about benefits, risks, and costs to society, to the healthcare system, and to human beings of using genomics in your healthcare. If you think about it, we've had genomics around for a long time, but when is the last time your doctor said to you, have you had your genome checked? And for most of us, that's actually never. We also mentor trainees at every level, from a few precocious high school students to a limited number of college students who want to do particularly summer experiences with us, to graduate and medical students, postdoctoral physicians, and junior faculty scientists. And we're very proud of not only the range of our trainees, but the diversity of our trainees, particularly a relationship that we have with Howard University for genetics training for many of their most promising undergraduates. In terms of diversity, we have a number of firsts. We had the first NIH study to subsidize elective sequencing to healthy adults of color. I'll be telling you a little bit more about our BabySeq study, which is the first study to return genomic results to African American and Hispanic newborns. And this is all related to the research we do in returning research results. And our middle study there is the world's first study to return research genomic results to African American participants, in this case in the Jackson Heart Study. So our portfolio is all of these different studies, many different firsts, and then we play secondary roles in the large million-person All of Us research program, where we design the genomic return of results, the Google Verily Project Baseline, and our own Mass General Brigham Biobank. But I'm going to zero in today on the two, I think, most impactful studies we've done. One we called the MedSeq study, which was sequencing apparently healthy adults, and the other, the BabySeq study, which is sequencing apparently healthy newborns. Now, why is this even controversial? Pardon me, you'd think that if you could actually predict the people who are more at risk for cancer or heart disease, that would be a good thing, right? Well, if you look on the left, certainly risk stratification, surveillance, and prevention is a good thing. Personal knowledge is a good thing. And by the way, sometimes when we think we're sequencing a person who has who's apparently healthy, they have some complaints or some medical problems that have been misdiagnosed, and the DNA leads us to a correct diagnosis. So that's pretty cool. But on the other side, genomics is really a collection of individually fairly rare conditions. So the prior probability of any of you or any of us having one of those conditions starts off fairly low. And when you're screening for things with a low prior probability, then the clinical utility and cost effectiveness is hard to calculate, and it might actually be negative. And then, as we all know, there's a relatively inadequate expertise in the medical workforce. So the MedSeq project was designed as a pilot study, a very expensive pilot study, but a pilot study to try to test for the medical, behavioral, and economic outcomes, at least in the short term. And so what we did is that we actually took a couple of hundred apparently healthy middle-aged adults, and we randomized them to just get family history or to get family history plus a genome report, which would look at over 5,000 genes. This had actually never been done before, even though, again, there have been individuals who've been sequenced. The idea of looking with medical rigor at 5,000 disease-associated genes in apparently healthy people had not been done before. Of course, there was a great deal of complexity to creating the workflow for variant filtration and variant curation. And I can go back to this if anyone wants to ask some specific questions about this. This has been now more or less normalized in almost every commercial lab, but at the time we were doing this, 2010, 2012, it was really sort of new stuff. And we generated a one-page report. Imagine you're sequencing an entire genome and you're going to give a one-page result to a primary care doctor with monogenic disease risk, carrier variants, pharmacogenomic associations, and even a couple of extra, like some polygenic risk scores or blood types. So what did we find? The most startling thing we found was that what we ended up calling unanticipated monogenic findings or unanticipated monogenic disease risks, not the disease diagnosis, but disease risks, we found in 20% of the apparently healthy population. And this was extravagantly unexpected. And then when we circled back to a subset of these, and you can see the ones in red there, we found that there was in fact evidence of, sorry, I'm hearing myself speaking on some of your phones. If any of you could set your microphones to mute, that might be helpful. So what we ended up seeing was that in about a quarter of these, there was phenotypic evidence of the condition that had been missed or misdiagnosed. And that was truly startling. And if you think of it, we've used DNA really, or conceptualized the use of DNA in two ways. One is obviously diagnosing a child or even an adult with a mysterious illness. We don't know what it is, so we're going to use sequencing to try to understand the molecular etiology of the disease and teach us something about that condition. The other way that we've been starting to talk about here is screening, and we've all been exposed to that concept even with direct-to-consumer testing, which is much inferior to this because it's only array-based. But the concept that, oh, we're going to screen your DNA for things you could get in the future is pretty familiar to us. In addition to those two conceptualizations, what we uncovered here was a third one, which is you have something already, and it either has symptoms or it doesn't have symptoms, but it has been underdiagnosed or misdiagnosed, and DNA sets you on the right track. So that's a kind of a cool new way of thinking about DNA, and that's why you'll hear me use the phrase pretty stereotypically, apparently healthy people, because so many of the individuals we did DNA testing on turned out to have underlying pathology going on, actually clinical complaints or pathology that no one was aware of, that was revealed through the DNA first. Now, one of the tropes has been, oh, you can't give this to primary care doctors, they'll make all sorts of mistakes. So we went through an elaborate taping, transcription, and evaluation of what the PCPs said to the patients about their reports. And amazingly, there were no high-risk errors. There were a few low-risk errors, mostly around confusion with recessive carrier states. So that was reassuring, even though, of course, this was a self-selected group of primary care physicians. Also, the notion that we did this in a randomized trial formula allowed us to more precisely compare things like healthcare spending in the 6 months following the disclosure of the conditions. So you can see that on the right side of the screen, there was a slightly increased spending, both in the mean and there was greater spending in those individuals who had monogenic disease risks than in those individuals who did not have monogenic disease risks on the right side. So clearly, if we start screening people with genomics, we are going to find things and we are going to spend more money. That's pretty unequivocal. The question is, will the value of this be worthwhile? And that's a harder question to answer, particularly in the short term, because you're finding risks for things like cancer, where it's pretty hard to know if you have improved their life by years in a real world situation. If you find that somebody has a genetic variant for increased susceptibility to hereditary forms of cancer, will they keep their appointments for surveillance? If they are surveilled, will you find a particular cancer in time to treat it more effectively? And as a result of all that, will that individual person live a longer, more fulfilling life? So that's a really hard question to do, and in some ways would take a larger, longer MedSeq trial. It would take perhaps 100,000 or 200,000 patients who were truly randomized to genome sequencing or not, and then were followed for 5 years, 10 years, 15 years. And that's a hard study, an expensive study to pull off. There's a pervasive narrative of catastrophic distress that pervades the field of genetics and people's perception of genetics. And I just want to tell you with great certainty that in this study and many others that we and others have done, we are able to rebut that narrative. It turns out that it's not that genetic information can't make people anxious. It's just that the people who self-select to receive such information manage it very well. And so whether we're talking about the people who just get whole genome sequencing, or we're talking about the people who get a monogenic disease risk, they just do not express greater anxiety or test-related distress. Now, if I've convinced you at all that it's an interesting idea to sequence adults, then the logical extension of that would be to sequence babies, because you can pick up a lot more genetic disease that might have emerged in infancy or childhood. In fact, this has been an expectation of the genomic revolution for many years. Francis started talking about this probably 20 years ago, but here happens to be a quote I found from 2012 when he said, a complete sequencing of newborns is not far away. Now, I don't know what he meant by far away, because here we are in 2023 and almost no one in the world is doing it yet. But I will say that lots of groups are now finally talking about it, planning for it, and piloting studies in this arena. And I'm very proud to say that the very first study to ever do this was our BabySeq project, funded in about 2015, getting started about a year after that. We once again randomized newborns and their pediatricians into two arms, one of which had whole exome sequencing and a comprehensive report. Now, in this case, we dropped the number of genes from 5,000 to 1,000 for various reasons. We tried to select genes that had strong and definitive evidence of association with the underlying disease, had a age of onset in the childhood range or adolescent range, and had relatively high penetrance. And to do that, we came up with about 880 genes, and then we added back in a certain number of genes that controversially included some adult onset cancer predisposition genes. And in the discussion, I can, if you're interested, I can tell you why we did that. But as it turned out, we ended up with just about 1,000, just under 1,000 genes. And again, it's really important and interesting to draw a distinction between the logic of screening, and the logic of diagnosis. So when you have a child or an adult who has a mysterious illness, you may do what's called indication-based testing. And for that, you want to cast a broader net. But when you're screening, as we mentioned, that prior probability is lower. So you want to pull in your criteria and make them make it less likely that you're going to get a finding in an individual that is never going to go on and get that disease, because you don't want to waste time and resources on the individuals who are least likely to get the disease. So, you go for the evidence levels that's the highest, and you go for the conditions that are most actionable. And importantly, instead of reporting variants of uncertain significance, which we do in indication-based testing, the laboratories do, we only report variants that have been adjudicated to be pathogenic or likely pathogenic. Now, what happened? Well, when we would simply ask people, and this is a great example of the difference between a hypothetical survey and what happens in real life. Of those who completed our survey, 70% said they were highly interested in sequencing for their brand new baby. I mean, same newborn units with brand new parents. But when we got finished going through all the hoops we had to go through to get our IRB protocol and our 20-page consent form and a script with all the horrible things that might happen to you and your baby if we sequence your baby, many people found this to be too overwhelming, and they didn't even really want to talk to us. Of those who talked to us enough to attend an enrollment session, go through the consent language, 2/3 did in fact participate. So depending on how you see this, it's good news, or it's glass half full, glass half empty, because if you could make this a little bit more frictionless, probably a lot more people would go for it. And even with 1,000 genes instead of 5,000, we found this remarkable statistic that 11% of these apparently healthy babies had a monogenic disease risk. And again, among the first 159 sequenced, you can see what we found here. And once again, I think it's not a coincidence, but a pattern. About a quarter of these, when you looked more deeply, had phenotypic evidence of the condition in question. Now, what do I mean by that? So if you look at the third line there, you see that ELN, or elastin mutation. And that is a mutation associated with a narrowing of your aorta, the big vessel in your chest. And at its worst, that can cause sudden death, but certainly can impact your exercise tolerance and cardiovascular strength. And this perfect little baby had normal heart sounds, was completely, had no clue. But when an echocardiogram was done following up on this genetic finding, sure enough, that baby had a mild, but definitely abnormal aortic stenosis. Now, once again, this doesn't mean you jump in and operate. This doesn't mean you do anything, but you can monitor that in case it gets worse with echocardiogram, a couple $100 for an echocardiogram every couple of years. And if something happens where that baby goes out on the playground and faints or loses consciousness or has some sort of exercise problem, boy, you've got a really, really rapid path to at least one of the possibilities. So again, it's not so much about diagnosis as it is about risk stratification and awareness of things that might happen in a child's future. You will notice in here that since we did open this up to a few genes that are expressed only in adults, you obviously don't get breast and ovarian cancer in a child, you don't get Lynch syndrome or colorectal cancer in a child. We very controversially found these mutations that are associated with adult onset. Now, this is highly objectionable to some ethicists, but others are coming around to our point of view, which was it can't be good for a child to lose their parent to cancer. And in finding this in the child, we actually also know that one of the parents is carrying. In none of these situations did the parent know they were carrying it. So we were able to discover unrecognized risk variants in the parent through the finding in the child. We also are able to take a look at some very extensive panel for carrier screening. So your commercial panels, I mean, what's done in a typical OBGYN office is pitiful. The standard of care is a sort of ridiculous 2 genes, and it's often done when the woman is pregnant. Many groups, particularly Ashkenazi Jewish groups, have demanded expanded carrier testing, and there are larger and larger commercial panels, which may go up to a maximum of 301 additional genes. But in BabySeq, among those 1,000 genes, many were recessive, and we found 566 genes in just the 159 babies we sequenced. So 47% of which would have been missed on even the biggest commercial expanded screening panel. So again, if you think it's a good thing to know about the carrier variants that you might be carrying, so that you and your partner can be warned in advance that you might produce a devastated child, and having been warned, have some options to do reproductive technologies like IVF, PGD, then sequencing all human beings, but in this case at birth, so that this is in your record, could be a very good thing. Again, I talked to you earlier about the narrative of catastrophic distress. Many hypothetical stories have been written about, oh, when the age of sequencing babies gets here, it's going to cause parents tremendous distress, anxiety, depression. Our randomized clinical trial methodology allowed us to look at this with great rigorous methodology. This was subsequently published just at the end of 2021 in JAMA Peds, and it shows that, in fact, wanting this information, receiving this information, whether you're talking about the negative genomes or even the subset that were positive, does not in any way increase your distress. We did additional cost follow-up. Again, the average for children with a monogenic disease risk was slightly higher than the average for children without a monogenic disease risk, but surprisingly modest difference. And it just speaks, I think, to the huge amount of variability in spending for healthcare for these apparently healthy adults. But this was pretty striking. Among the babies that were carrying monogenic findings, we not only had surveillance and follow-up in the infants, but into the first degree and second degree relatives. So parents, adult uncles and aunts, all of whom were prompted in some cases to get tested for the genetic mutation that we found, and even with just a few mutations in cancer predisposition genes, this information prompted 3 risk-reducing surgeries, which is extraordinary. Quite a bit of media has emerged from this, and some of it is praising our work, some of it is warning about our work, some of it is really leaning into the controversies. For example, the fact that we screened for a couple of adult onset conditions, but it makes for fascinating reading because this is coming and people are paying attention to it. We have real stories from parents. I'm not sure if I have in some talks that are longer, I offer a little video there. And we're now funded, after a great deal of difficulty getting refunded because some of the reviewers were so conservative about this. We are now funded to continue with the BabySeq 2 project, which is underway at all of these sites that you can see on here: Mass General Brigham, Mount Sinai in New York City, CHOP in Philadelphia, Beaumont Health in Detroit, University of Alabama in Birmingham, Baylor College of Medicine. And very excited about that. We've just the last couple of weeks started recruiting for this. We're really struggling to enroll a representative cohort because it's mostly well-educated, predominantly persons of European ancestry who volunteer for these studies. So we've gone to a lot of effort to try to enroll a more representative cohort. The people who, I'm just the leader, but the people who really run this study is an extraordinary team of multiple sites over the two BabySeq NIH projects. And the dream here, what we're really pursuing, is the notion that wherever you bring genomics into play, it is a lifelong value, particularly if you can find a way to update it with ongoing current scientific information, or with information that is complemented from the individual. So you can start in the upper right there, and where we started with BabySeq, and you can, right today, we can do expanded screening for treatment for conditions that are treatable, but are not currently getting screened for on the state mandated heel stick test. There are tons of learning disabilities, autism, and other either manageable or treatable conditions in childhood that could be screened for with genomics. Genomics won't catch them all, but it could catch probably 50% of them. In young adulthood, we might at that point want to get preconception screening, because as children become of reproductive age, they might want to know what mutations they're carrying. As they enter early adulthood, they might want to know if they are predisposed toward type 2 diabetes, or polygenic risk scores for atrial fibrillation, or common forms of cancer, as well as, of course, the hereditary forms of cancer. And then the cycle continues. So that's the notion that this is a potentially lifelong resource. And going back to the babies, it's a little striking how many conditions are in fact treatable that we're not currently screening for. It's not obvious because each of them is individually rare, but together they are actually quite common. And they are often not thought of the same way because they're treated in different ways. Some are treated with diet, some are treated with medications, some are treated with specialized immunoglobulins, and some are even treated with bone marrow transplants, which are quite significant. And there's approximately 4 cell and gene therapies that are approved by the FDA today, but there's over 400 in development. So this is going to be an exploding area, because the treatable conditions are exploding, and the number of conditions the minimum number of conditions that we screen for on the conventional heel stick that every mother gets in the hospital, that every baby gets in the hospital once they're born, is somewhat frozen at 35 to 60. So we're very proud to be leaders in this space. There are additional groups around the world that are now entering this space. There's a group in New York City. There's a group, Genomics England. There's groups in Europe. And virtually every country in the world has reached out to talk to us about our BabySeq experience, because they want to do this on either a hospital level or a regional level, or some of them are even talking about a countrywide level. And I think a major question is, how does it grow constructively? So in October of 2022, we assembled the 8 groups in the world that are the farthest ahead, and that was a spectacular conference called the ICONS Conference, or the International Conference on Newborn Sequencing. And I'm really happy to say that that went extremely well, and we now are creating a consortium that will exchange ideas and outcome measures and try to harmonize scientific data as rapidly as possible on this. And so the consortium will be meeting again in October of 2023 in London. And so at this point, I will wrap up and hopefully encourage you guys to comment and discuss this and go back into depth on anything you'd like me to go into depth on. My email is there, and I'd as is the website, our Twitter and Instagram handles. And I would also encourage you, if you're interested, to get your own genome sequence. We have a telemedicine, sort of under the radar telemedicine service now that it is out of pocket and it is still fairly expensive. What most people order ends up between about $2,000 and $6,000, depending on how elaborate they want. But it's an extraordinary learning experience. And we continue to find percentages of apparently healthy individuals carrying mutations at exactly the rates I've been describing to you. So let me stop sharing for a second. And if some of you would like to turn your cameras on, then I can see you, because I can't see a single living face in this yet. I'd love to see you. But either way, if you'd like to ask a question, I'd love to discuss anything that you're interested in.
Well, I can certainly start because I think this is amazing. And I think this is the direction that we need to move in immediately, because there's so many good things that could come out of it. And the only way that I know of, this is why my camera was off. I don't know why it's doing this, but I don't know how to fix it either. But I can certainly see a number of ways that you can be more responsible for your own healthcare with more knowledge. And I also think if that becomes more open and in the public view, people will become less afraid of it and more concerned about the benefits and less focused on the fear. So given that, my question is, WEDI is, I've told you, we've talked about it before, but WEDI is an advisor to HHS on a number of different things, including recommendations for things that they view as very important to the WEDI contingent of members. And a lot of times we're tasked with understanding an issue and then doing work, which is what the WEDI Workgroup should be about, doing work to make sure that HHS is aware or is more understanding of different types of things that are going out so that it can influence policy to make some of these changes. So if we gave you just a blanket overall statement that says, WEDI wants to get more involved in getting these kinds of things into mainstream, can you give me some, or give us some suggestions for areas that would make sense?
Absolutely. I mean, and it's a perfect time to talk about this from our point of view, because we've done the NIH thing for 20 years now, really, and those are great. We're appreciative, and we've been able to incrementally, I think, demonstrate these things. But NIH isn't set up to do large-scale studies that really need to be done. So I remember once when a billionaire was visiting our hospital 10 years ago, she asked, what would you do with $100 million? And I was like, da, da, da. I was completely frozen like a deer in the headlights. But, I made it a habit since then to say, I'll have an answer for that the next time I'm asked. And I do have answers for that, depending on whether someone is most interested in screening adults for adult onset conditions. We've been helping healthcare systems around the country launch these programs. We've helped. I've consulted to Geisinger and North Shore. We've been very involved with Sanford in South Dakota and Beaumont in Detroit, and we're talking to a number of other healthcare systems. So, what could we do with more significant commitment from the government? One of those Medicare, Medicaid reimbursement with evidence collection type deals, which instead of being applied to a controversial treatment like the Alzheimer's disease treatment, which is the last time I heard it discussed, was applied to a screening program like this, trying to jumpstart genomic medicine in healthcare systems. Or what could we do with an all virtual, instead of a 23andMe, take the best pieces of that and create an all virtual but very rigorous medical experience supported by telemedicine that we've all gotten used to using now since post-pandemic. So I think there are some definite ideas, Rosalind, and if anybody there is interested in follow-up conversations, we'd love to have some of those.
Okay. That sounds
I mean,
wonderful.
for some of you, I recognize Grant Wood's name, I think, down there. If it's the same Grant Wood I've known about for years in informatics.
Yes,
Yep.
it is.
Some of you are very, are very sophisticated already about this. So, you probably have questions you'd like to dive into in any part, which I'd love to try to respond to.
Great.
I'll ask the question quickly. Sorry, Dr. Green, that I joined a little bit too late. But my first thought is, have you been working at all with the folks in San Diego with the rapid sequence program? I was just curious about that.
Yeah, if you're talking about Rady and Stephen Kingsmore, yeah. So Stephen Kingsmore is extraordinary leader in bringing rapid sequencing into the neonatal intensive care unit, and everything he's built is formulated on taking the genetic features of the child in front of you and zeroing in on the most efficient way to sequence rapidly to determine the genetic etiology of that sick child. More recently, he's trying to expand the idea of that rapid sequencing into a more of a screening concept. But he's starting with the most at-risk children, premature children, children already in the NICU, brothers and sisters of NICU babies, and so forth, which is, I think, a smart way to start. So that's his beginnings program. And I've been helping a little bit with sharing our protocols and our consent forms to help them get that off the ground. But as best I can tell, they haven't sequenced yet a single apparently healthy child. And when they do that, it's still a very different approach than saying, let's take a population-wide approach with all comers, more associated with perhaps what we're doing at the state labs for newborn screening. So he is one of the founding members of this ICONS. He spoke at ICONS. I'm speaking at his thing coming up in March, and we're very committed to working together. And it's a great complementarity to different approaches. Yeah,
great.
In my case, I don't think that the rapidity of the sequencing is as important as it obviously is with sick kids. So if you've got a baby, you took that baby home, the baby seems to be doing well, we're no longer screening for the things in the immediate postnatal period. Most of those have either manifested and that child is sick, or you've screened for them on conventional newborn screening. We're talking about the first year of life, and we should get that sequence done in the first month if we can. But to my way of thinking, it's not as essential. It's more essential to plug that into the baby's health care in a rational way, to bring the pediatricians into that, to be able to normalize risk stratification when you do find a mutation, so people don't panic, they do the right degree of follow-up, than it is to do it extraordinarily quickly in that circumstance.
A follow-up question: if the healthcare system adopts the Rady methodology to do that rapid sequencing because they want to, diagnose, say, a newborn in a very quick manner, if they had that capability set up, wouldn't they then be ready to do what you want to do at the same time? I mean, could they work together in that manner?
Maybe, but there's a lot of ifs in there. The first if is, do they have a sequencer on site? Are they going to use an outside lab? Many hospitals don't even have, as you know, the sequencing capability. Secondly, even if they did have the ability, let's say they had the new exon on site, if they could spend $1 million to have that on site, do they have a team that can keep it in tip-top shape and run it? Francis talked about $200 a genome, but we all know he was talking about a fully loaded, often discounted set of reagents that were running every lane all the time to get that kind of efficiencies. Third, do they have any kind of interpretive team, software algorithms? I mean, maybe a company like Fabric could come in and shortcut that at some point. And then finally, do they have anything like the infrastructure needed to return those and follow up on them, particularly for ultra rare conditions they're likely to find, even if they're treatable? So I don't know. I'm still of the opinion that sequencing and even interpretation are on their way to becoming commodities, and that the real challenges here are human workflow challenges. And some of them can be solved with technology, and some of them are going to be slower to be taught.
Right.
So I don't think it necessarily follows that a large community hospital in the Midwest that says, yeah, we need on-site sequencing to do, maybe they can get that. But wouldn't they just be just as well to draw a sample, ship it overnight to, an Invitae, Myriad, GeneDx, or have them do a rapid, high quality, low cost sequence and electronically get that report back in a short time? I mean, the optimization that Stephen has had to do to get that kind of turnaround, I don't think it's easily replicated. But you may know more about it.
Well, I don't. I just know that they have been, Rady has been open to working with healthcare systems who want to adopt their processes. But I haven't heard from Stephen in a while as to how many people have successfully implemented that yet. And so I think that the questions you raise are the big questions that every healthcare system has to overcome first. Yeah.
Yeah.
Hey, Dr. Green, this is Vasuki, and it was great presentation and information. One of the things I have is not related to baby though. For adults, now we see so much of cancer and all that. It wouldn't be a good protocol to do the sequencing done before they decide on what kind of treatment they are giving, and be right about the cancer diagnostics, and about is targeted therapies, and even similar to this mRNA, there is DNA-based vaccines that are developed basically after sequencing. I think not the whole crowd is know the knowledge is not being spread. If that is spread and we do the right action once a cancer is detected or something, that would enable everyone to do sequencing, know more about it, and whether we are going for the right. So are there any efforts on those dimensions?
Yes, if you're talking about tumor sequencing and tailored medication for the genomics of the cancer tumor itself, that is of course
yeah, yeah.
Are you talking about germline sequencing for discovery of hereditary cancer like BRCA1 and 2?
Yeah, there are two things, right? Sorry, yeah, sequencing just for the right treatment, and
yeah,
on the other one, when you're diagnosed with something, either your genomic sequencing from your network itself to know whether to find it the right type of diagnosis, things like that. I mean,
yeah, you were breaking up a little bit, so I'm not sure if I heard you, but let me just I don't know a lot about oncology, so I usually don't talk too much about that. But I think as you pointed out, there are really two areas, and that is in those particular people carrying hereditary mutations like BRCA1, we can screen them early, and just the fact that they are carrying those mutations may indicate that they should be treated differently. And then, as we started to say, among people with tumors, there is a huge industry that you're all aware of sequencing the cancer tumor itself and trying to tailor chemotherapies along those lines. So those are big areas. In fact, when healthcare systems say, I want to get started with precision medicine, often that's really what they mean. I try to sort of divide the world into everything oncology and everything else. And on everything else, you've got screening for the things I've been talking about. You've got pharmacogenomics, you've got carrier testing, and you've got the new hot area of polygenic risk scores. Anyway, if anybody, I think Rosalind will have to wrap up soon, but if anybody would like to get their own genome sequenced, or you just like to follow up and on this discussion, particularly if you have avenues where you think we could collaborate, or where you could introduce me to opportunities for larger scale projects, I'd be very grateful. And I put my email once again in the chat.
Well, thank you so much. This has been so informative and just given us a whole bunch of things to think about. As a follow-up, I will be setting up a meeting with you and Weedy to talk about the kinds of things that we could do to move some of these things forward. And separately, I've got a couple other things that we'll be able to work on together. So thank you so much for your time, and thank everybody here.
That would be wonderful. For those of you that I don't know, great to see you. Grant and Rosalind, who I had met before, wonderful to see you too. And I hope to talk to you again.
Okay.
Bye-bye.
Thank you.
Thank you,
Bye.
Dr. Green.